my name is Linda Avery Patson. I'm here to do a tutorial on endotracheal intubation. What is intubation? Basically what it is, it's an insertion into the trachea of an airway that's going to enable us to breathe for the patient when they can't do them themselves. That's the biggest reason why we do it. In the EMS field, we do it for lots of different types of situations. Cardiopulmonary arrest, when CPR is in place, if they are in respiratory arrest, if they're not breathing adequately for themselves, if they are cyanotic and they just can't maintain a patent airway, or if we have to give them some sort of gastric lavage because they've overdosed. Those are the main reasons that we would do it. I've seen it most in the cardiopulmonary arrest, our patients that are dead and we're trying to bring them back to life. There's lots of advantages to endotracheal intubation, but it is very controversial right now. It does provide an unobstructed airway and it prevents aspiration. Those are the main reasons to do it. Using a bag valve mask in an airway device, it just allows that gastric contents to come back up and then to aspirate, causing death, pneumonia, and different types of things. With that cuffed airway in the endotracheal intubation, that's not going to happen. It can easily be maintained for a long period of time. So when we have return of spontaneous circulation, our patient comes back into life, then we are able to continue that airway and maintain that airway for a longer period of time. At some point, medications can be passed to the airway device, not recommended anymore. We went over ACLS prior, but just so that you do realize that medications, although they can be passed, not recommended anymore. The lungs are just too wet. The disadvantages of endotracheal intubation. This is where the controversy arises. The big one, it needs training. Not only does it need training, you need to maintain the proper training. That's the big thing. Even once you've learned it on a mannequin, you go into your OR clinical settings, you've got intubation down pat. Now you go out and working in the field as a paramedic, and you don't have a cardiac arrest or any of those indications we just talked about. You haven't intubated in quite some time. You don't use it, you lose it, right? So that's the big thing. That training and that continuation of the training, it's just not there. There's contraindications for intubation, and that's an important thing to note. You not only do everything you can in an airway, but you need to know when you can't do certain procedures, and intubation is one of them. Certain cervical fractures, are really something you shouldn't be nunking with as far as an airway, advanced airway at that point. Bag valve mask works just fine. Different fractures, if there's edema there, if you're not going to be able to pass the tube, we certainly cannot do that. At that point, we're going to have to move on to an even further advanced airway, even more controversial, which is a cricothyrotomy. Again, knowing when to do stuff are advanced airways, when not to do it, very important. Once you've decided, okay, I'm going to intubate my patient, now I need to make sure I have the required equipment. And on the slide here is the equipment. It's also provided in handout that I've given you. The big thing is to make sure you have all of your equipment ready prior to starting. Your patient is only going to get one shot at this. You don't need to be looking around for your laryngoscope or if the batteries don't work or things like that. So I'm not going to read you the slide. The information is here. Gather your equipment, have it set out, and get ready to go. Here's the procedure, and we've talked about it in class, and we will continue to do a practical portion of this until you get it right, and then we'll keep doing it because, like I said, you don't use it, you lose it. Making sure you position your airway, position your patient, get the equipment ready, then go ahead, insert the laryngoscope, sweep the tongue away. Hopefully you can visualize the cords. If you cannot, there's different devices we can use, and we'll learn about them in the hands-on session as far as gum bougies and things like that. But visualize the airway, insert the tube, take out the stylet, inflate the cuff, and then try to ventilate your patient. That's the big part. One of our biggest chances for lawsuit in the EMS field is a airway that is not secure. And we can lose an airway. We need to make sure that we have successful placement of that tube, and we have confirmed its placement in at least 3 different ways. Chest x-ray, of course, isn't available in an ambulance, so we're going to listen to lung sounds, we're going to use our capnography, and we're going to look for chest rise. They must have all 3 things, or we cannot consider this tube successful, and it has to be pulled. This brings us to this slide, the removal of the endotracheal tube. Now, there's 2 things I want to talk to you about with this. Like I just told you, you've somehow intubated the esophagus. You couldn't confirm placement. We need to pull that tube. It's not a secure airway. We're going to cause more damage than do any good, and it needs to go. The other reason for extubation really in the pre-hospital field isn't there. If your patient is fighting the tube, which would be a reason to remove that tube if it was a successful placement, we can use medications such as Versed to take them down and to keep them down. At any rate, if you are going to extubate, you need medical control orders. Take away the tape. If you have an OPA in the patient's mouth, get rid of that. Have your suction prepared and ready. Deflate the cuff. Please deflate the cuff before you remove it, and then withdraw in one smooth motion. They will aspirate. You will need the suction, and you need to make sure that you still maintain a patent airway. Okay. That was just a really quick version of endotracheal intubation. If you have any questions, please don't hesitate to call me. It's a life-saving procedure, but it's very controversial at this point in the EMS field, and actually even in different OR settings that will be coming. So please give me a call if you have any questions. Thank you.